guys, I want you to do something with me. Okay, attention at the front. I want you to do something with me. We just had a really hard test. Every nursing student who does acid-base imbalance, that test hurts their head. That one and the electrolyte test are some of the hardest tests in MedSurg 1, okay? And that's part of why we have them as quizzes instead of lumping them in with your unit test, so that you can focus on the other material in the unit test, but just individually on the electrolytes and then the acid base, right? So I'll grade those, and then the next class we have, I'll kind of go back and talk about why it was this one and what that meant, just for a little bit, so we can try to secure our understanding of some of those. Because not only did you have to have the information, you had to use it, right? And that's what the NCLEX makes you do. And that's a big step up when we get to MedSurg, those types of questions. And you're doing well. I know every point matters in MedSurg. So keep working and keep studying. And I'm going to keep giving you tips and tricks on how to break the questions down. So you're looking at the STEM, so you're getting the extra insight in what is this question really asking me? Because sometimes those additional strategies help you pick out what's important and rule out some of the answers listed. Does that make sense? So I gave a few tips and tricks with our midweek reminder, and I'll keep doing those sorts of things because that just helps you process, okay, that's a lot of information in a question. What do they want me to pick out from it? Does that make sense? Yeah. So I just wanted to pat you on the back and say you got through a hard test. We'll grade it. We'll see how it goes. I've had good and bad scores already. I had 100% and I've had a 5 out of 10. I don't have everything graded yet. But we'll see what it is, and I'll try to get those posted before I leave today. Okay. So I want you all to take a deep breath in with me. Hold it. Blow out the candles. Next door, you too. If you are not experiencing anxiety with nursing school, God bless you. Most people do feel some anxiety with nursing school. We are learning to take care of people, save people's lives, and keep safety as a priority for our patients. So of course the material is difficult, but you can do it. You got to keep studying at it, and I'm going to keep giving you information to try to help clump it together, make it understandable, and tips and tricks for remembering things, okay? So I know that was a hard test, but I think you're going to do better than you thought, and I'll let you know, and we'll look at it, okay? Now, and we've got through electrolytes, and we've got through acid-base imbalance, we've got through IV infusion, and today we're going to talk about medical surgical nursing. What a mouthful. That's why we call it MedSurg, right? A couple things to remember about MedSurg. It's not so much the place where you work, it's what you're doing. So even if you don't work a MedSurg floor, you're going to take MedSurg information and concepts wherever you go in nursing. That's why if you're acute care, if you're a home health nurse, it doesn't matter. You're going to use the concepts presented in MedSurg nursing. That's why we have so many MedSurg classes, because it is at the heart of nursing itself. And there's so many pieces to it. You remember the last couple PowerPoints I put extra, more information at the end, right? Because there's always more to know, which is kind of exciting once you get the basics down that you can keep building. Nurses are lifetime learners. Things change. How they did Foley care 10 years ago, the Foley kit that they had 10 years ago is so different from now. So nurses are lifetime learners, and that means you are a lifetime learner. It does get a little bit better once you get some of this fundamental information down pat, okay? So we'll get through that. Just know that it's part of the process. That's what we're doing. Okay, let me get my screen where it's going. Can you hear me next door okay?
Yep, we can.
Yep, we can. Yep, we can. I don't usually have any problems with people here. Maybe the opposite. Okay, so let's dive in. Oh, also, just a heads up, I did update the chapters on the syllabus from the 9th edition to the 10th edition of the book, the one that you have. So if you want to print that out again, it won't be as confusing, and it's updated on the syllabus on Moodle. So we're doing chapters 3 and 4 for the 10th edition. And going forward, it'll be up to date. It'll be just one less thing you have to worry about. Okay, we already kind of talked about MedSurg nursing, right? It's what you practice, not where, because it goes everywhere with you. And it involves all of the medical conditions that we treat as nurses. It involves everything from heart failure to kidney failure to GERD and everything in between. MedSurg floors often have exacerbations of conditions with the heart, with the kidney, sometimes neuro, etc. Some of the main areas. The skin system with cellulitis, infection in the blood. But also, we do pre and post-op, right? So after a procedure, after a surgery, you're at risk for complications. And so you get monitored, usually at like a PACU, someplace right after surgery where they keep a close eye on you. And then you go to MedSurg to recover and cover up, get better. MedSurg nurses can have anywhere from 4 to 8 patients. And it kind of depends on the acuity of your patient as far as how many you get. Where I work at Cox, we have on some miraculous days, I've had just 4. We usually have 6. And our patients can be on lots of medications and be critically ill. We're almost like a step down in our transitional care unit. Wouldn't you say? Caitlin works there too. We have some really sick people. So that keeps you busy. And sometimes it's nice if you have 6 patients, if 1 or 2 of them are walkie-talkies, are ones that can get up and move around on their own, and we're monitoring and we're giving medications, but they're not at the point of, am I going to have to rapid them? Am I going to have to do some sort of major intervention to keep them alive? Because those patients take extra care, right? That's not on the test. But MedSurg is important. Acid-base, we just kind of went over that. We just had a quiz on it. This is going to be review. I'm going to let you look at those before. I will not, this is a good hint, I will not have any more questions about acid-base on your quiz next week. You've already covered that. You got 10 questions out of it today. It's information you still need to know, and stuff that could be on your final. When I write your final, it will be from questions on the quizzes and tests, right? Right? So we will review a couple things next week. We'll go over both your IV infusion test, which I thought you did a pretty darn good job on. An excellent job on your sticks yesterday. Everybody did a really good job with those live sticks. I loved it. And then we'll also go over the acid-base test that we took today. All right? That gives you a chance to get that information stuck in your head and be better prepared both for the NCLEX and for your final in this class. Okay? General information there that we covered. And then we jump on in to cellular regeneration. So this chapter really is a broad overview of all the things that are involved in MedSurg. So we talk about cellular growth. That's just where we grow, where our cells divide and grow. That can be a natural process. Replication, same sort of process, right? Our red blood cells die, but we need to make more. And what's the process for that? And then differentiation, that's where the cells are, they're made special. It's that extra education of the cell, right? So that some cells are geared for our neurosystem and some cells are geared for our cardiac system. And that differentiation happens as part of cellular regulation. Cellular regulation is part of what keeps us balanced. What's the term for balanced body? Homeostasis, right? So it's really important. You're probably noticing this trend, right? Electrolytes are important for homeostasis. Acid-base balance is important for homeostasis. Cellular regulation is important for homeostasis. All of the parts of the body systems are working together to try to find balance. So when you can identify what's normal assessment, you can figure out then, oh, well, that's not normal. And that gives you tips. Okay, now I need to do something because it's outside of the normal window. So a lot of this class is making sure that you can identify what's normal so that when you have your assessment, you know, okay, I need additional steps because it's outside of normal limits, or it's within normal limits, I'm just going to continue to monitor. In nursing, nothing is ever done. You're always continuing to monitor. Wouldn't you say, Melissa? Yeah, because things can change in a heartbeat. 1 minute they're fine, the next minute they've had a stroke. Something to that effect. I hope that's not your experience. So you can have positive or negative effects. When our body gets into the system where there's a mutation or a problem and we're over-replicating cells that are malignant or have some sort of problem with them, we get cancer. You can also hear that referred to as a neoplasm or a tumor, right? And that's, sometimes they have different growth rates. It can be a slow growth rate or it can be a super fast growth rate. Neoplasms that have a fast growth rate are sometimes more difficult to handle, right? Because it can spread before you can get it treated. Risk factors for problems with cellular regulation. If you see this big sign that says stop smoking, it's a huge factor. It puts you at risk for heart disease, it puts you at risk for vascular issues, lung disease, and then it also puts you at increased risk for cancer. My mom had cancer. She's the reason that I moved back to Missouri. I was teaching English in Tulsa, kind of inner city sort of program. And mom got cancer and we moved home to take care of her. Well, she'd been a lifetime smoker. She was born in the 40s and it wasn't understood the way it is today. And I don't know if she would have cared even if it was, honestly. She was a smoker for anxiety and she enjoyed it. She had a lifetime of smoking and it turned into colon cancer, which is not uncommon. And so she had to quit smoking, which was pretty difficult to do in her 70s, but she did it. Older age, your body's had a lot of experience. It's a little worn out. So the older you are, the more at risk you are for breakdown or problems maintaining that homeostasis, right? Your kidneys don't filter as well. Sometimes your heart doesn't beat as well. Sometimes there's problems with your blood pressure. Smoking's a big issue. Poor nutrition, whether you're young or old, can increase your risk for cancer, like obesity, or you can also have problems if you don't have any nutrition, right? So like anorexics can have problems with homeostasis. Physical inactivity, that sedentary lifestyle, our body needs to move. You may have heard the physical therapists at the hospital say things like mobility is life. Ours say that quite a bit. And that's true because that helps our system stay within the normal limits. That helps them balance out and keep homeostasis. Environmental pollutants, air, water, soil, we're not immune to those. We're exposed to some things that can cause problems with our cellular regulation, radiation, some medications, and genetic predisposition. So whenever you're assessing a patient, we kind of ask for a history, don't we? You know, that form that we fill out when we go to the doctor's office, has your mom, has your dad, your grandma, your grandpa had a stroke? Have they had a heart attack? Have they had? And that just kind of gives an indication of your susceptibility at times, depending on the condition or the predisposition. So you want to make sure that you're changing the factors that you can. You can change your activity level. You can change your nutrition. You can change your smoking, but you can't change your genetics, right? And so that's something you can teach to your patients as well. Because a lot of nursing is teaching. Right? Imagine going into the hospital super sick and finding out that you're diabetic. Your life is getting ready to change. For the nurse, that's a shift, but for the patient, that's a life. So being able to educate them can change someone's life, help them be more comfortable with the diagnosis, and then compliant. And when I say compliant, that really means do things to help themselves. Right? It's not about, oh, I told you to do something and you didn't do it. It's about, if you can do these things, it'll help control your blood sugar and you'll feel better and you'll have a better life. Guys, get me excited. Just get me excited. I love this stuff. So when we're talking about tumor growth or neoplasms, they can be benign or malignant. Benign means they're not spreading. It's an individual localized source. Malignant means it can move around, and that's a bigger risk, right? When we assess, we talk about histories. We've already mentioned that. Sometimes a cancer can be visible or palpable. When my grandpa, he had cancer, he died of cancer. He had brain tumors, and they literally, by the time he passed, you could palpate them on his head. That's not always the case, right? But based on where his were and the size of them, and he had quite a bit of neuro changes as well. How we find neoplasms, the CT, MRI, sometimes scopes or a biopsy. Interventions, we're going to tell them to change the things that they can change. Don't smoke, increase your activity, good nutrition. And then we're going to do screenings to see if we can catch something in the early stages, we're more likely to be able to treat it than if we don't find it until it's the late stages. When it gets to the late stages, it's more likely to spread through the body. That causes more complications. It's more difficult to get our body back in balance. Okay, this next section is important. What does Bailey do when things are important? I think she hits the board. This next section is important. Clotting. Not only is it important for this class, this is important for your patients. This is a problem that you can encounter at any time with the patient. Clotting is a complex, multi-step process with a cascade. What I kind of want you to know is that parts of your blood thicken and they form this semi-solid mass. That's a clot. This semi-solid mass can block flow of blood. What does blood carry? Oxygen, right? And if we don't have any oxygen getting somewhere, what do our cells need to stay alive? So we can kill ourselves in an area. And when that happens in our brain, we can have stroke, right? And that can cause long-term damage, sometimes permanent, depending on rehabilitation and how the stroke develops. It can be triggered by an injury, and sometimes it can be like a diseased process. The risk here for clots are immobility. What puts you at increased risk for clots? Next door. What did I just say?
Immobility is what they said.
That's the right answer. So you need to, our patients in the hospital, they're less mobile than before, right? That's why a lot of them will be on an anticoagulant. That's a medication that thins their blood because thinner blood is less likely to clot, right? And some people with chronic conditions will be on an anticoagulant long term. Otherwise, it's just prevention measures in the hospital or the critical care setting. For folks who are at risk for clots, we want to make sure that they're moving at home, right? If they've got a desk job, let me tell you, sometimes that computer sucks you in and the next thing you know, it's been hours and you've worked on PowerPoints for that long. I'm sure it happens just like that for you too, only studying, right? They need to get up and move every 2 hours. What about planes, trains, and automobiles? Long trips put them at risk for clots. Clots can be where? Next door, name a place where a clot can show up.
Heart, brain.
Legs, lung, heart, brain.
Check, check, check. Exactly. Depending on where it goes. But if we're sitting in a car and we've got our leg creased, we're at risk for a clot in our leg, right? And then sometimes that clot can move to other places or become an embolism and go to our lungs. Yes, so it was a great question. She said, so does that mean people for their job who have to sit a long time, drive around, fly a plane are at higher risk? And the answer is yes. If we've got people who are at risk, whether it's by some sort of medical condition or their job, just like you mentioned, we want to make sure we're educating them and telling them you need to be moving around every couple hours. Because if you're just sitting there, you could develop a DVT. And the older you are, sometimes your risk is higher too. Good. That was very insightful. I loved that. That was the next slide.
So if you're a pilot, is that affected anymore being like higher altitude?
That's a really good question. I'm not sure if altitude does, but immobility is certainly the big factor there. And if they've got a 12-hour flight, I don't know how comfortable I am thinking about my pilot getting up and walking around every 2 hours. I guess that's when the co-pilot comes in.
A lot of them are back.
Okay, Coach said so. They said Coach said so.
Coach said that it does, altitude does affect.
Coach said altitude does affect.
Increases your risk? Yeah.
Yes.
Good. I love our critical thinkers. Okay, this is just some visual components. You know, I like pictures and illustrations, things that help us put the material into a visual component. So you can be at high risk, moderate risk, or average risk for clots. And this just sort of identifies some of the high risk, moderate, and average risk factors. What would you think are some of the high risks for developing a clot? Surgeries put you at risk. Someone in the back? Surgery. Hospitalization we've already talked about, right? Because you've got less mobility and you're sick. What about a knee or hip replacement? Liver failure can be a problem. A major trauma, like a car accident, an NBA. And why would leg paralysis put you at big risk? Same thing. It's that immobility. You're not moving. That's right. Moderate risk, we have older than 65. Your risk increases with age. Those trips by plane over 4 hours or car or bus. Cancer and chemotherapy can change how your body clots, so you become at more risk. Some of the medications that we use to treat cancer increases your risk for clotting. Hormone replacement therapy, pregnancy or recently giving birth, prior blood clot in the family. Like when my mom had me, she had a PE. It's a pretty big deal, and that's kind of common, not common, like everybody has it, but you see that after they've had a baby. Sometimes people will throw a PE. Bed rest over 3 days, obesity increases your risk as well, and sometimes that genetic component. The average risk is active people under 40. Awesome, I no longer meet that category at all. And these are just some pictures of clot formation. The book Cascade, this is a simplified version. We have platelets and blood cells that come to the area of trauma, and they form together with fibrin and stitch clot. Pretty interesting. Okay, just some more on clotting. Thrombosis, that's usually in the veins of the legs, and if it moves around, that becomes an embolus. And that, so if it goes from the leg, it can go to the head, it can go to the lungs, and any sort of like internal bleeding can make it harder for your body to clot because you're actively bleeding. There are some assessment points to know about when people are clotting or have problems clotting. So we'll see if people are having problems clotting, we might see frank blood. Next door, just tell me, what is frank blood? When you hear that term, what does it mean?
They said light colored blood.
Bright colored blood. Yeah, bright. It's red. It's not dark. It's bright colored blood. Yep. And that can be in your urine or your stool. Frank bleeding from the gums or nose can also happen. Purpura is bleeding under the skin, and then there's ecchymosis, which means bruising. I think when I was in nursing school, that was a term that took me a minute to get, but we use it all the time. Ecchymosis means bruising, yeah. Petechiae, that's the pinpoint example here. That shows that your body's having a hard time clotting because you've got little pieces of blood going to the top. Increased risk for clotting, venous thrombosis. So if we have a clot that's in the venous system, we're going to see redness, swelling, and warmth. Commit that to memory. Not only is it important for testing purposes, it's important for your assessment of your patient, right? Redness, swelling, and warmth. An arterial clot is a big issue and requires major intervention. Interventions that we do, we teach them to watch for signs and symptoms of bleeding and bruising. We teach them about mobility and moving every 2 hours. They need to hydrate and avoid crossing their legs, stop smoking, and watch for signs and symptoms. Sometimes we have folks who have impaired clotting, or they're at risk for developing a clot, and will be on an anticoagulant. You won't be tested on the names of an anticoagulant. This is just for your information because you might have an NCLEX questionnaire down the road. It's something you do need to know. Anticoagulants thin the blood so that it's less likely to form a clot. Thick blood is more likely to clot. Does that make sense? Yeah. So we want our blood to be a little bit thinner if we're at risk for doing a clot. People at risk can have different disease processes. One that's pretty common is atrial fibrillation. That's an irregular rhythm of the heart. And again, this isn't a cardiac test, but just to know the regular beat of the heart is lub dub, lub dub, lub dub, or squeeze push, squeeze push, squeeze push. And AFib is like stirring before we squeeze push. It's like when you're stirring together dough. The more you stir, the thicker it gets. So it has an irregular contraction, so extra in the atrium. Squeeze, push, stir, 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 squeeze, push, stir, 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 squeeze, push. That extra stirring puts it at risk for developing a clot because it thickens the blood. Does that make sense? So our AFib patients, our atrial fibrillation patients, are going to be on a chronic anticoagulant to reduce their risk of stroke, because that's the big risk of clot, or one of the big risks. And so they might be on warfarin or another medication like Eliquis is the gold standard right now. It's just information, but worth mentioning. Our INR is one of the labs that we use to track how anticoagulated someone is, you know, how quickly their blood will clot or not clot. PT and INR go together. The INR rate is 0.8 to 1.1. When we have anticoagulated people, we want it higher than that. Usually, you know, 2.5 to 3 is kind of the goal for an anticoagulated person. So their labs, when you're looking at them as their nurse, you would expect that to be higher. If it's not, then it wouldn't be therapeutic for them. But you have to know your patient to know that. INR is 0.8 to 1.1. That's the regular. That's the regular. And then if they're on an anticoagulant, we like them to be 2.5. Okay. Good question. This is just another picture. I love those pictures, and it goes over signs and symptoms. A lot of assessment involves the signs and symptoms of something going wrong. If you know that that sign or symptom you see in your patient could indicate a problem, then you can get some labs or some testing done to see if that problem exists, right? Who spends the most time with the patient, the nurse or the doctor? The nurse and the aide. We're in there all the time, aren't we? Yeah, you and your aide are a team, and you guys need to work together to take care of your patients. So swelling, pain, and tenderness, warmth, those are 3 that we've mentioned before, right? And depending on where they are, you might also have some chest pain, fever, weakness, and sweating. The INR, it tells us the clot factor is our blood thin or thick. So, and that was 0.8 to 1.1. And then the PT is called prothrombin. You don't really need to know that yet, but that is like how long it takes to clot. So it helps us understand the thickness of the blood. And then if they're on a blood thinner, we would expect their INR to be higher, right? Because that's the goal of therapy. We want it to be higher because that means it's thinner and less likely to clot.
What would we be expecting?
2.5. Yeah, good question. Okay, time to apply some of the stuff we just talked about. This is a picture. We're going to assess the picture. I know we can't touch it, but let me tell you about it. The patient reports redness, warmth, tenderness, and pain in the right calf. Can you see that the right calf is bigger than the left calf? Can you see the color changes? I'd be concerned about a clot there, right? So what are we going to do? We've done a physical assessment, and we found our signs and symptoms for a clot. So the patient's symptomatic. What are we going to do? I'm so sorry, what? Notify the provider, and that's right. We're going to say, hey, I see this in the patient. What kind of order would we expect? What did you say next door?
He said heparin.
Okay, yeah, let's confirm it first, but you would expect that because once you have one clot, you're at risk for more. So you're going to have something called a venous duplex ultrasound. You're going to do an ultrasound over the red warm area to see if there's a clot in the venous system, right? And so that just lets them look. They're going to try and compress the veins. If they don't compress, they suspect a clot, right? Because there's something blocking that vein from compressing. And sometimes, depending on, they can also show like blood flow. Impeded blood flow could be an indicator of a clot too. And then what Lee was saying is, hey, and once we've got a confirmed clot, we would expect to anticoagulate that patient, right? Because once they have one clot, they're at risk for more clots. One of the ways we can anticoagulate them is heparin administration. Good. So what are the signs and symptoms of a DVT? Okay.
It's going to be swollen. Like,
It's usually bigger. It's not always red. If it's deep, it may not be red, but the swelling happens. There's an inflammatory response that's triggered by that clot being stuck. Yes, in the back. The D-dimer, that's a blood test that tells us how much inflammation is in the body. So an elevated D-dimer could indicate a clot. Good question. I just love this. Okay, we got through the clotting section. I know there's a whole bunch of stuff in here. Give me a little bit and I'll let you have a break. That is not, is that the right time? Awesome. Awesome. Okay. Cognition, that is our ability to understand what's going on around us. That's alert and oriented times 3 or 4. Lots of time in the hospital we say 3. Do you know who you are? Do you know where you are? Do you know when it is? And then sometimes at like nursing homes it's times 4, which is they understand what's going on. So that's how we assess cognition. It is one of the most important assessments a nurse can do. If your patient has effective cognition, if they're alert and oriented, they can make decisions for themselves. No matter what process they have, unless they have a guardian where the state has said, hey, this guardian makes decisions for them because they've been found incompetent, meaning not able to make good decisions for themselves. But most of the time, it's just, are they alert and oriented? Is their cognition intact? Because they have a right to make good or bad choices. They have a right to make choices. And that was really something that I still struggle with when people make choices that are bad for them and sometimes life-threatening for them. We educate, educate, educate. We want them to understand the consequences, but it is not our choice. It is the patient's choice. And then you get into some discussion about patients who have altered cognition, and then who makes the decision, right? And those are things we're going to discuss in this class today too. Impaired cognition can be caused by advanced age. Please know that dementia is not an expected finding with aging. I know we see it all the time, but it is not expected. You will not always have dementia just because you're old. Disease disorders, brain tumor, stroke, hypoxia can change your cognition. We know acid-base imbalance can change cognition. Depression, environmental exposures, substance abuse, fluid electrolyte imbalances. Also, throughout these PowerPoints, you'll notice that there are page numbers in here that reflect additional information in your book. Page 35 just has good information about delirium and dementia, just being able to distinguish the two and understanding what they are. It could be physiological consequences. You have short or long term. You know, it makes it harder for them to talk sometimes. They can have delusions and hallucinations. And then it's really hard to keep them safe, right? When they get scared, what do they want to do? They want to escape. They want to run. They want to get out of bed. They may be so sick that that's a risk, right? And then we have to get into how do we keep them safe? How do we keep them in the bed or with someone when they're moving about without taking their rights away? Avoid risk factors. We're going to tell them, hey, no drugs, lifestyle behaviors, stimulate the intellectual part of your brain, music, puzzles, whatever, promote safety, and we're going to reorient all the time. This is a CAM assessment. We're going to practice using it if I don't run out of time today. And this helps us understand more about assessing the patient for cognitive level. Right? And I told you that in nursing, that cognitive assessment is one of the biggest things we do. It can show signs of problems with fluid imbalance, electrolyte imbalance, base acid imbalance, all kinds of disease issues or body issues outside of homeostasis. Acute onset and fluctuating course. So we're trying to see, is this the patient's baseline? Are they always this confused? Or is this something new? If it's something new, we're more concerned about it, right? Because that means something has changed that has caused it. And we're on the investigation to find out what changed that caused it. Does it get better or worse at different times of the day? Like nighttime, like sundown. Inattention, did the patient have difficulty focusing, or were they like a squirrel here and there, and this conversation, right? Hard to focus, don't know where, changing the topic all the time. Disorganized thinking, that goes along with the inattention. Irrelevant conversation, unclear, illogical. Sometimes you can toss in, there's grandma in the corner and grandma's been gone for 20 years. No, some illogical conversation or having conversations that aren't there. And then the altered level of consciousness. Would you call them alert, lethargic, vigilant? Those are the people that always want to jump out of bed, right? They're the ones that are like, what's going on? Who's there? What's that sound? Oh man, poor people. I worked psych for a while, and people on, oh shoot. We couldn't pick it up on a test because we didn't have, it was an expensive test and it wasn't one of the regular ones. And they were on drugs and they came in and they thought the wall would teleport them to another world. And they literally knocked themselves unconscious running into the wall. And they have increased epinephrine, like they have increased energy, adrenaline, right, when they're high. And so I've seen a little bitty guy coming down off meth break an oak door with one quick kick down the middle because he thought people were chasing him, killing him. Like he was seeing these people chasing him, killing him, and I'm trying to get him a sweatshirt, and he kicks the door like that without a window with a lock on it and breaks it down the middle. And he was not 5'5", maybe 140 pounds. So that adrenaline. So safety for you and your patient. We're going to use this CAM assessment. Comfort is super important, right? When our patients have increased pain, we're going to see that in their vital signs sometimes, right? There's a big discussion about what is pain. Is it the 5th vital sign? That's kind of where we go. We still go with that today. But sometimes people are pain medication seeking, and you're going to have to use all of your assessment skills. Ultimately, pain is what the patient says it is. And then we have to assess or decide how that's affecting the patient, right? It is not our goal for them to be pain-free. It is our goal to manage their pain. Managed pain has less symptoms attached to it. When our pain is out of control and not managed, we'll see our blood pressure go up. We'll see the breathing increase, right? We might see them pale and their heart rate increase. We can see changes in their vital signs. And sometimes you won't see that. Some people just don't present that way. I've seen a lot of older patients who are almost stoic. I know they're in pain because they're rigid. They're not telling me anything, but they look terribly uncomfortable, and they're very hesitant to take pain medication. Does that make sense? Sometimes it's emotional stress and it's anxiety. It's assessing your patient. Oh, elimination. Being able to poop and pee is super important. That is a very easy way of saying it. If someone can't poop, how miserable are they? Yes. And there can be a variety of factors that can make elimination difficult. I can't pee, I can't poop. It can kill you if it's not resolved, right? There's a reason it's uncomfortable. It's our body's body saying, hey, we got to fix this. I can't keep all of these toxins in here without causing major damage. Okay? So when we talk about MedSurg nursing, elimination issues are big. Excretion of waste from the body. We talk about continence and incontinence and retention of these fluids. Let's just talk about urination for a minute. Continence is that voluntary control. That means, hey, I got to go pee. I can make it to the bathroom and go when I tell my body to go and not have any dribbles in between. Incontinence is kind of a lack of control. That happens sometimes after having babies, after having surgeries. It could be a neurological bladder where we've had a stroke or some sort of neuro disease that has caused us to have inefficient control with our bladder. What is some of the risks for folks who are regularly incontinent? Oh, I love you guys. Yes, that is good critical thinking. Man, that urine is acidic, right? We're excreting those hydrogen ions from our last test. All over the body, it's more acidic than our skin, and it's breaking the skin down. How comfortable is it if someone has an open area in their peri area, in their nether regions? Really uncomfortable. What is the risk for infection? Super high. We want to make sure that we're taking preventative measures for incontinence because we don't want it to get to the point where we have skin breakdown, because that puts our patients at risk for infection and discomfort, right? So we're not just going to place a Foley in someone. Remember, our interventions go from least invasive first. So we're going to do things like we might have a barrier cream. They're incontinent every once in a while. We put a barrier cream on every time that we clean them up, when they get cleaned up, depending on their cognition and their mobility. We might do things like toilet training or bladder training. I hear it called that. That's where every 2 hours we take them to the bathroom. They may be 60 years old and we're like, we're going to the bathroom. And sometimes that's super helpful with our older folks who might have dementia because it creates a pattern and a routine. And they might not register that they need to urinate, but now we've got a pattern and a routine. It is labor heavy. We got to take them to the bathroom every 2 hours. How do they get up? Probably not easily. Right? Those walkie-talkies aren't very common in the hospital. But that's one of the ways that we can prevent skin breakdown and becoming an infection. Okay, you guys agree. We're going to look at when we're assessing for elimination issues, we're going to try to determine risk factors. We're going to look at skin. The perineal area and the buttocks are really common for skin breakdown. We're going to look at the frequency, amount, consistency, and characteristics of urine and stool. So a fully formed bowel movement comes out of the body and goes in the toilet. But let's say we're incontinent with diarrhea. One, that's embarrassing for the patient, right? It's uncomfortable. We don't want to leave them sitting in that. That is a huge infection risk. That's a skin breakdown risk. That's also got some anxiousness for the patient. It can like damage your relationship with them if they felt like they've been sitting there for a long time in their own excrement. And it's terrible for their skin because they can get red, heated, warm, uncomfortable, and then eventually break out with tissue impairment. We can do some tests to see if we have an infection or like E. coli or some sort of issue going on. So have you ever heard of C. diff? Next door, have you heard of C. diff?
Yes. Is it chicken pox?
People have multiple times a day, maybe 10, 15 times a day. When I was studying for the NCLEX, I was an aide on the MedSurg floor, and we had lots of patients with C. diff at that time. And I thought I contracted C. diff taking care of my patients because I was going to the bathroom 10 to 15 times a day. But really, I went and had it tested, which is super fun to give a stool sample to a lab technician. Yeah, you know what? It's just lots of weird things. You're like, oh. But turns out I didn't have C. diff. I had anxiety over the NCLEX. Cleared up right after I passed. It was good. Anxiety response, generalized anxiety response. Okay, so we're going to teach them if they have diarrhea, they might have a brat diet, or we're going to have bulk-forming agents. If they have constipation, like maybe they take pain medicine, we're going to encourage things like fiber intake, maybe Miralax, something that is non-addictive. It doesn't have any long-term negative effects. It's just a fiber supplement. And that bladder training is really big because it's a non-pharmacological intervention. Nursing's big on non-pharmacological interventions, things we can do without a doctor's order. Fluid and electrolytes, we've already had a whole unit on that. Please make sure that you know how to assess for fluid overload and dehydration. Okay? Those are big deals. You kind of see those popping up on multiple tests. Mine, Ms. Hendricks, et cetera, and it will continue to do so throughout your career. It's one of the assessments you need to be able to do in your sleep for your patients. We're going to skip over that because we've already taught it. Gas exchange is the process of oxygen transported to the cells and then carbon dioxide transported away from the cells. You know, this is the ventilation, breathing in and breathing out. Risk factors for problems with gas exchange. Acute or chronic breathing problems can affect like diaphragm dysfunction, skeletal muscle contractility. Who's ever heard of tripoding? What is it? So, Gwen, tell me, what is that?
Anybody? Tripoding?
Would be like bending over a podium, isn't it? Like where you're,
Like
That's right.
bending over like a podium.
does that make sense what I'm trying to say?
Yeah, exactly. It's that leaning forward, maybe on their knees, maybe on a table, usually seated because they don't have energy to stand up. They probably fall down. And what it does is opens up the airway and gives more surface area for that gas exchange. There's usually something impeding it. It's not at 100%. It's not at homeostasis, right? And so they're doing all sorts of compensation measures to get more breathing, more air in where it needs to go, and CO2 out. Yeah.
Those are those little pumps that Walmart did.
Yes, and it can be really, yes, and there can be a heart failure component to some people, and some people it's COPD or emphysema. It could be a number of factors, but it's ultimately an issue with gas exchange.
So why does that?
Opens up, it gives you more space for the air, the gas to exchange. If you're laying flat and you might have a couple extra pounds on you, or you might be a lady, all of that weight just sort of goes on your chest, right? It makes it harder to breathe. So you'll see people with issues with gas exchange sitting straight up or leaning over. If they're leaning over, that is definitely labored breathing. Last week we talked about what do we see in a respiratory assessment, right? One of the things we're looking for, are they unlabored or are they labored? That's a sign that they're labored. Good question. Risk factors for gas exchange issues. We talked about asthma. I have asthma. My little thing says it ain't easy being wheezy. Prolonged immobility can cause problems with your breathing. It gets weak. Anytime you have had a surgery, you're at risk for pneumonia. That's one of the most common secondary infections. So we're going to push incentive spirometer use because it makes us open up those airways. There's little alveoli at the bases of our lungs. They're like little suction cups. When I was in nursing school, I was talking to Jared, my husband, about these alveoli. My little kid goes, "We have ravioli in our lungs?" No ravioli, alveoli. And when we don't take deep breaths, that's why we promote deep breath, turn in cough, incentive spirometer. When they get suctioned together, there's less surface area for gas exchange. So it's encouraging problems, right? And we don't need that. So we want to make sure that our patients are deep breathing so that we have gas exchange and we don't have fluid buildup that can lead to a problem. Hey, there's a picture of an incentive spirometer. Question next door, you're on the spot. You ready?
We're ready.
Incentive spirometer. Do you breathe in or breathe out when you're doing it?
Out.
In. You're breathing air into your lungs, and it's measuring how much air is in your lungs. And with repetition and experience, we can increase the air we can take into the lungs, right? So sometimes you'll see people misusing them by blowing out. That's the pickle, right? The incentive spirometer, as pictured here, is all about bringing the air in. So it's like sucking a straw for a milkshake. That's often how I describe it.
Try,
And
guys.
holding it. Yeah, so that's why I asked. Most people have that backwards at first. Respiratory assessment, we're looking for problems with gas exchange. Might be crackles, wheezing, rhonchi, ABG, CBC, or a lab test, chest x-ray, a CT, a VQ scan. I don't think I was very familiar with that until I got on the floor. It's another way to check for like a PE. Like if they can't have the contrast with the CT that allows them to see really well, they might do a VQ scan. It's not as effective as a CT. You can have a negative VQ scan and still have a PE, but they're usually small at that point. Immunity. Hey, that's a big hot topic right now, isn't it? With COVID and all of the things that have come along with COVID. Give me 5 more minutes and we'll do a break. Sherry, remind me, okay? I'm sure you're ready. I'm sure you're ready for it, guys. So there's different types of immunity. There's the natural active immunity, the natural passive immunity, and then the artificial side. So we've got active, passive, natural, and active, passive, artificial. So our natural active immunity is like our body's creating antibodies to fight. And the passive immunities is like when we're carrying a baby and we give our antibodies to the baby. And then we have like vaccinations and such that's part of the artificial side. So active artificial immunity is vaccination or immunization. And then artificial passive immunity is where we get transfusions or immunoglobulins. Sorry, easily entertained. Yeah. Older age has reduced immunity. That's something that I want you to know. Sometimes people don't engage in immunizations. It's not our job to judge them. It's our job to educate and let them make decisions for themselves. Does that make sense? Okay, here's the side effects of it. Here's what it says it does for you. Here's the research that shows that. Now you decide. Right? We do let them know that without many of our immunizations, you're at risk for contracting XYZ, and that's what these diseases look like. So they know more information about it. It's like the difference of saying, oh, I made French food tonight. Aren't you excited? And that's such a broad term that you might think, yeah, absolutely. But then you get to the dish and it's escargot. It's snails. Or you get to the dish and it's like croissants with chocolate and wonderful latte, right? So it could be, you want to give more detail, more information, and then they can decide if they like it or not. Risk factors, chronic drug therapy, so steroids, long-term steroid use. What does steroid use do to our immune system? Brings it down. Yeah, helps them breathe. It's an important therapy, but my goodness, it makes them at risk for contracting infections because their immune system's broken. Substance abuse, one of the reasons people get sick when they've been using substances because it destroys their immune system. And then genetic risk as well. This is another picture because you know I love illustrations. It talks about active and passive immunity and where you find them. We talked about a weakened immune system might be medication related like Humira, or if you have an autoimmune disease where your body's attacking itself, sometimes they'll put you on an immunosuppressant so that you're not attacking yourself so much. But the flip side of that is you're at risk for infection, right? So you got to be more careful, moderating or changing the risks that you can. You eat well, you exercise, you avoid big crowds. Hand washing is the #1 way to stop the spread of disease. You should know that in your sleep. Hand washing. How many of you think differently about hand washing now that you're in nursing school? I don't know that I had any concept. I mean, I wash my hands, but I wash them totally differently now. And if I see somebody leave that bathroom and they don't wash their hands, I'm likely to tell them nicely. I'm not a bear, but still, like, it freaks me out. I'm like, hey, there's some soap over there, water, right?
Somebody didn't wash their hands and some lady hollered out, "Wash your hands, you dirty."
Okay, so maybe you don't have to, you just be nice about it, but let's encourage people to wash their hands. I agree. Okay, it's 9:35. We still have some information to get through. We'll have a minute to walk around and reduce your risk for what? Blood clots. And come back at 9:42. 9:42. I'm gonna drink some coffee. Been okay? someone else said they had a hard time sleeping. They had a kiddo in their house. Was out.
Oh, I didn't have that problem. I have it on this.
Oh, that makes it hard too.
Really good, but he's a good.
That's like my biggest fear.
So I used to not press my legs or I thought sideways for the same question. Now I know it's much more wider things. I don't know, just like little things. The more I think about them, it just starts getting right.
Today. Fine, I'm fine. Everything's fine, dude.
Everything's fine. Okay.
I just think it's like most people to the right way. Get excited about this stuff. And this stuff is a little bit easier. No, it's not easy, but it's a little bit easier than acid-base styles, I think. So what will be on our test? For this next week? So this next?
For the like first exam.
The units?
Yeah.
So let's look at our little syllabus that tells us that we have, so next week, we're gonna have a quiz over these two chapters, and then we're gonna talk about pain management and end of life. That's chapters 5 and 8. Our test itself is gonna be over 3, 4, 5, and 8. So these two chapters and the two chapters we go over next week. There might be some questions about like fluid balance or whatever, that like, because this is kind of a summary unit, but it'll be questions like over fluid overload, etc. Yeah. Yeah, assessment's important, definitely. That nursing process is a great way to sort of study, you know, assessment, what's the diagnosis, what's going on, plan, what do they think they're going to do about it, intervention, what they actually do about it, and then evaluating, assessing again to see if it works. So ADPI is a big one to know. So like sometimes with NCLEX questions, you're like, oh, it asks you what you need to do first. If you haven't assessed, that's the first thing you did, because the nursing process, assess. So that's a good hint. I don't think anybody told me that until like a bit into it. I'm like, it helps when you're like, okay, and you always start to overthink the questions. Maybe not everyone. I should remember everyone is not like me. But I think that's a common thing. People overthink. Trying to get the stem of the question solved. Like, what do they want me to know? What are they trying to evaluate what I know?
But it,
Right, we're almost there. I'll check next door and then I'm gonna get started. Let's say I have one more minute. This was full. That might be part of my excitement. Sherry's like, man, I don't know.
No, I'm still working on my teaching. I think I need a lot.
Yep, me too. That should be Friday. All right, let's hop on in and talk about infection. It's a pretty significant topic within MedSurg, within nursing itself. So when we talk about infection, it's the invasion of pathogens into the body that multiply and cause disease and illness. It messes up our homeostasis, right? When someone has an infection, what are some lab changes that we might see?
white blood cells.
Oh, you guys are doing so good. Yeah. White blood cells go up, right? What about their vitals? What kinds of changes would we see in their vitals? Temperature, and what would it do?
Right.
It really goes up, right? What about our heart rate?
Might be faster.
It usually gets a little bit faster, and sometimes our respiratory rate too. Our immune system's kicking in, and so it's working hard, and it's making our metabolism go up, and our temperature's going up, and so everything's working a little faster. So at the start, we work faster. Over time, if it continues, we kind of drop off as we start to die. Yeah, it's really straightforward there. Good. There's a process. You don't just die unless it's septic. It's important to notice something. It can be bacteria. It can be viruses. Okay, so we don't give antibiotics for viruses, right? It's not really going to help it, and it's going to increase your risk of it not working the next time you have a bacterial illness. Fungi, parasites, or protozoa are other types. If you work with kids, sometimes they get pinworms. That's a fun way to have to test for that. So pinworms like to hide in the anus, and you'll notice a lot of scratching and redness in the peri area. And how they test for that is they usually have the parent look for it at night. They like to come out between 3 or 4 in the morning, and you put tape on their bum and pull it off and see if you grab some little worms. Put it in a specimen container. Nope, it's for real. It's for real. And kids aren't the only ones that get them. You can find it on MedSurg. And scabies and lice. One time we had a patient, schizophrenic patient, so they're notorious for not doing self-cares, right? If you're hearing other voices, you're distracted. So she came in and she was not in a great state, and we had to clean her up. We gowned up. Were you there that day? It was, that's right. She had so much lice in her hair. She'd been to jail and they had shaved the sides. but I don't think they treated her for the lice. So we treated her with Nix for the lice, but we ended up having to shave out knots in her hair. We had to get permission for that, which was an interesting process. But then we had to clean her. And while we were brushing, I was brushing her teeth, and the lice were crawling on my garments. From the hair that had gotten in her mouth had lice in it. So she'd been infested for a really long time. She left without lice. Yeah. I treated immediately. I went home, mixed myself, and bleached myself. You can use a little bit of bleach in your bath water. Yeah, so like, you may have, who knows? She had a lot of bugs.
I want to say she did. She had bed bugs so much.
Yeah, so bed bugs are hard to get rid of. Skinnies are hard to get rid of. They tunnel under your skin and leave these little silver marks. Itchy. Nurses, we tease that MRSA, fine, VRE, fine, COVID, fine, bed bugs and lice, leave me alone. Something about it makes this an area that I still love. Yep. I pack a wound, I can clean a trach, do all kinds of nasty things, but I just really didn't enjoy the lice. The lice in the mouth. Okay. So it can be a localized infection like cellulitis, so in just one area, or it can be a systemic infection, so it's in the bloodstream and it's everywhere. Sepsis is an important concept you'll learn even more about, but that's when it might start locally, but it spreads systemically, and over time your different organ systems shut down. One of the first ones to shut down are often the kidneys. We shunt blood away from them. Shunt blood means we move it to where it's needed most. So our feet don't get as much blood, but our heart and our brain do, right? We need that most. Risk factors, any sort of immunocompromisation, HIV, chemo, autoimmune disease, chronic illness, COPD, and diabetes are at high risk for infection all the time because they're immunocompromised. And diabetes, their blood sugar's out of whack a lot, right? Unless it got it under good control. An infection causes your blood sugar to get wonky, usually high, but I've definitely seen in brittle type 1s that it can go low too. But infection can cause changes in their blood sugar. Contaminated food or water, impaired tissue integrity, that broken skin like we talked about with incontinence. That's a big reason why it's important to do that bladder training for some of our folks. Exposure to contagions, flu, TB, COVID. Continuous or frequent stress. You wouldn't know anything about that in nursing school, would you? Assessment. We get a history to determine risk or exposure. With our COVID screening, if you've been around anybody who's had COVID, do you have any signs and symptoms? For a localized infection, we look for redness, warmth, pain, and swelling. Ask about elimination. We're trying to see if they're continent or incontinent, because if they are incontinent, they're at risk for periarea skin breakdown. Labs, we talked about the white blood cell count, that ESR also is an indicator of inflammation in the body. A positive blood culture is an indication that there's infection in the blood. So that's how we can tell it went from localized to systemic. If the blood is positive, then the whole body is positive. Intervention, viruses are not treated with antibiotics. They just take time, and we give supportive measures. Maybe fluids. Viruses can be terrible. Viruses can kill people, but there's not an antibiotic that fixes it.
Is there anything to do for someone who's severely compromised by the virus?
You're going to treat the symptoms. So we're going to give them fluids. We're going to give them Zofran or something for nausea. We're going to give them we might even have to give them some nutrition, depending on how severe it is. And they can receive supportive therapy, but an antibiotic's not going to fix it. So by being super sick with the virus, what are a lot of the signs and symptoms of it? We have nausea, vomiting, diarrhea. I sound like a Pepto commercial. So we're going to treat that nausea and vomiting and the diarrhea. They're likely not eating or drinking because they don't feel well, so we might give them some fluids, or if they're really severe and shutting down, we might give them some nutrition. So we're going to manage symptoms, but we can't give an antibiotic because it won't. I mean, they can if it's prophylactically, but we try not to overuse antibiotics so that they're available when we do have a bacterial infection or a fungal infection. Good question. We treat bacterial infections with antibiotics, increase our fluids and electrolytes to flush it out of the system. We increase protein. This is a ding ding moment. Nutrition, infection, protein. Those should all go together in your mind. Nutrition, infection, and protein should all go together in your mind. Protein helps the body heal. And it's sometimes what we don't ingest when we're sick, right? So you'll see people in the hospital have protein supplements, right? There's a variety of them. Maybe they're double protein on their meals. Maybe they have a Liquicell. Maybe they have a Mighty Shake. Maybe they have an Ensure, a protein-based Ensure. Yes. Infection, protein. Yes, that's good. I want you to associate those together. When we're talking about nutrition and we've got infection or we want to push protein. Does that make sense?
Yeah, like the idea behind feed a hole, like a list that you have a hole, you have to feed it, so it's a virus, and then you give it food, protein.
I hadn't thought of that, but it could be. That could be where they get that from. But especially protein here, we want to push that because it helps our body fight infection. And rest. Your body needs rest to fight. If you've had COVID, you know that it makes you super tired and you just want to rest way more than you have time to rest because your body's still healing. This is an example of cellulitis, and you see that it's marked. The edges are marked because as we do treatment, we expect that redness to shrink, right? That's one of the ways we can assess or evaluate whether our interventions are working. It's just a good thing to know.
How many signs of presence did you do?
So usually we will see something on the skin, so that redness, warmth, there'll be maybe a cut or some sort of trauma that's happened, and then we'll do blood work and we'll have an elevated white blood count. We see some signs and symptoms in the body, and then we need some sort of confirmation. Sometimes they'll treat even if their white blood cell count's normal, if they suspect, based on the symptoms. But usually we got some blood work that shows there's an infection. Good question. Yes, Melissa. It has to do with inflammation. It just shows that there's inflammation in the body. And an infection like cellulitis, sometimes that's difficult. And cellulitis also puts you at risk for DVT because we've got that inflammation, right? So there's not great blood flow sometimes. So location and pulses, you're going to check pulses distal to it, right? If we've got a clot, our pulse might be weaker below it, distal below it. Yes, of the skin. Yes. And it can, if it's not treated in the skin, it can go systemic and become bacteremia where we have infection in the blood. What great questions. Okay, mobility. Mobility is life. Mobility is life. When we don't have mobility, we encourage disease and decline. Okay. We talk about ADLs. That's what? Activities of daily life. You know, we're seeing if they can take care of their basic human needs. Part of safety for before we send them home, right? And also what do we need to do to help care for them? Because when you can't meet your daily needs, you're at risk for decline. You're at risk for infection and falls and sickness and problems with elimination, fluid imbalances, all the things that we've already talked about. Risk factors, dysfunction of the musculoskeletal or nervous system, severe brain or spinal cord injuries puts you at risk for immobility, right? A bedridden or prolonged bed rest. These are all things that can happen and then you can't move. And then it compounds the problem. It makes it worse, doesn't it? I heard one physician tell a patient, she was in geriatric care, so she dealt with people over 65 in this case, that for every day in the acute care setting, she would need 3 days to recover. So they sent her to a skilled facility after discharge with the anticipation that she'd be there for 15 days because she'd been in acute care for 5. No, does it always work out that way? No, but that's just a sign that you decline quickly. 6 hours in bed and your muscles start to decline. So sleep even. But usually we get up and we go. I know, 6 hours extra in bed at the hospital, your muscles start to decline. Wow, I know. It's just crazy how big a role mobility plays in our health. Complications of immobility. These are important. I don't remember if they're on the test or not. These are important. They will be in some capacity somewhere. Pressure injury, we don't move them, we don't turn them. They're sick, so their skin is fragile. It breaks down. Pressure injury can lead to an infection and pain in our patient. Constipation, if they're not moving, they're not moving. So if they're not moving their body, their bowels aren't moving. You might have to give them something to help with that or increase their mobility. Weight gain or loss, atrophy, that's where the muscles are used, and so they decline and they shrink. Venous clots, urinary stones, so increased clot risk with immobility. We know that, right? Because they're supposed to get out and walk every 2 hours. Urinary stones and depression. We're looking for the patient's environment. We'll do an assessment. We're looking for fall risks. Functional assessments we'll cover in chapter 6 coming soon, but that's a lot about those ADLs, muscle strength and range of motion. Nursing is a part of an interdisciplinary team. You're going to work with physical therapy and occupational therapists. Occupational therapists specialize in those ADLs. Can they brush their teeth? Can they get up to the bathroom? Can they dress themselves? Interventions that you'll commonly see related to mobility and the risks associated with mobility: active and passive range of motion every 2 hours, heel pumps, those SCDs, that decreases our DVT and formation, that reduces our risk for clot. Turn and reposition every 2 hours, keep skin clean and dry. That's that incontinence stuff, right? Promote nutrition, fiber, protein, calcium, and hydration. Encourage deep breathing and coughing exercises. Why? Get your lungs moving, Melissa says. That reduces your risk for fluid collecting. That helps your respiration stay in normal limits and reduces your risk for developing pneumonia. Good. Work with other disciplines like therapy. Nutrition, that's eating and drinking. Wish that was a test question, right? Proteins, carbohydrates, fats, vitamins, minerals, all compose nutrition or nutrients for our body. If we have inadequate nutrients, we have malnutrition, and that can be too little or too much. So you can be undernourished or overnourished. Older adults have acute chronic diseases, oral health. If their dentures don't fit, they're less likely to eat. If they don't fit well and they've got mouth sores, they might not eat. Have you ever had maybe you don't have to work in the medical field to go to nursing school, but sometimes patients will get food and they can't eat it because it's crunchy and hard and they have no teeth and they need a soft diet, right? And then they're not getting the nutrition they need. One meal may not be a big deal, but all of the meals would be. Obesity, type 2 diabetes, we don't absorb things the same way. Metabolic syndrome, similar issue. Financial impairment, some people can't afford to eat. And sometimes they can't afford to eat because of choices they make for drugs or spending their money on drinking something else. And sometimes it's just a bad draw, you know? It's my soapbox. We take care of everyone. You don't have to agree with their life choices to care about them and take care of them, right? When you become a nurse, you're taking care of your patients and you care about your patients, even when they're not nice to you. It doesn't mean you have to put yourself in harm's way. It doesn't mean that you don't take care of yourself, but it means that nursing, you don't have to like the person to take good care of them, right? You don't have to like what they're doing. But that's not our job. Our job is not to judge, it's to care. All right, stepping on this. Physiological consequences, increase vitamins. We just need to make sure that we're promoting nutrition because it promotes wound healing, especially the proteins. The big point here. When we do an assessment, we'll do a health history. We'll see what they typically eat at home. We do their height, weight, and BMI to see if they're in the typical normal range. BMI between 19 and 24.9 is normal. We're not talking about what mine is. They can do some labs to see if we're lacking some nutrients, especially like albumin is a big one, which is related to protein development and protein intake. Healthy lifestyle, drug therapy. Some drugs make you excrete vitamins and not absorb things right, so knowing their medication list is important. And then our patients that have had bariatric surgery, they don't absorb real well. Sometimes they'll have their medications in liquid form at home because it absorbs a little easier for them. And they'll come to the hospital and they'll be on the oral PO pill type, and you might have to get that changed because their absorption is a little bit different. Perfusion. Next door, you're on the spot. You ready? What is perfusion? I didn't hear it.
Blood flow.
Blood flow, that's the short and sweet answer. Yeah, so perfusion is getting blood to an area. We know that's important because it brings nutrition and it takes out waste. We know it's important because it brings in oxygen. It keeps that area of the body alive. If we don't have perfusion, we don't have blood flow and we don't have life to that area. You kill the wrong area of the body and you kill the person, right? We don't have blood flow to the heart, we can have a heart attack, right? We don't have blood flow to a part of our brain, we can have a stroke. Right? We don't have blood flow to our leg, we can lose it, have to have it amputated. Right? So perfusion is important. How do we assess for perfusion? I think I just spit on Sherry. Sorry. Cap refill? Cap refill, yeah, we're seeing that when we press in underneath the nail, like here on the thumb bed, that it'll go pale and then it'll be pink again within 3 seconds. That's normal. We also do it on the toes, and we can check pulses too, right? You should be able to have pulses and feel them, but distally, especially those on your feet, the top of your foot, that helps us assess blood flow in the legs. Certain chronic conditions decrease our blood flow, our perfusion, such as COPD, heart failure, renal failure, and diabetes. Okay. Risk factors that can be changed, that means our modifiable risk factors. Smoking, don't do it. I'm not always sorry. Physical activity, increase it, and don't be obese. Non-modifiable, cannot change, age, gender, and genetics. So you're more likely to have problems if your family had problems with that area. So when we have problems with perfusion, we see issues such as skin ulcers. If we're not getting blood to the skin, then it starts to break down. And once it breaks down, we have an opening and we have a skin ulcer. Gangrene turns black, necrotic, and we lose it, whatever that limb is. Systemic or life-threatening perfusion issues. We talked about the MI, the stroke, shock. Shock, you don't have enough blood in your body, you had a CBA, you had a car accident, and you bled out. Assessment, we do a health history and a family history to see your risk of perfusion issues, and then we look at signs and symptoms. The central, dyspnea, shortness of breath, dizziness, syncope, that's either you faint or you stand up and you feel like you're going to faint. Chest pain, low blood pressure, change in orientation, increased heart rate. So when you have issues with perfusion, your heart's going to try and pump harder and faster to get the blood to go to the eye, to perfuse better. Peripheral, have you ever seen, like my dad was a very hairy gentleman, very hairy. His arms are hairy, his legs were hairy. And then in his old age, suddenly he had no hair on his legs at all. Did he shave it? No, he didn't shave it. He had problems with perfusion, right? So we didn't have good blood flow and some vascular issues in his legs, and so he had less hair on his legs. So looking at hair distribution can give you an indicator or a sign of that perfusion, that blood flow. Pallor, so if there's blood, it's nice and pink or appropriate color. When the blood's not there, it's pale. When the blood's not there, it's cool because the blood's warm, right? That's why when we have too much fluid on our body, it's often cool in that area because it's farther away from the blood. Cyanosis means the blue or the gray around the lips or fingertips. So we do some things to help increase perfusion, like vasodilating. What does vasodilate mean? Expand the vasculature, yes. Promotes blood flow. And sometimes we'll do surgery where they'll stent or open up a vein. If you vasodilate, your blood pressure goes down because it's bigger, so there's less pressure. I'm sorry, I'm deaf. Lower blood pressure. Vasoconstrict, more pressure. Yes. Constrict. That's right. Good. So that's good. What she was saying is vasodilate means there's more space for the blood to flow through, so there's less pressure inside the vein. When we vasoconstrict, there's less room inside the vein, so there's more pressure. Sensory perception. That's can they feel and interact with the world around them. When we have sensory deprivation, we have mobility issues and we have increased risk for harm to ourselves, right? Numbness, tingling, stroke, aging can all have an effect on our ability to sense the world around us. Risk factors, aging, we have less visual acuity and hearing. Taking care of a patient that can't hear you. You gotta yell really loud sometimes. It's good in report to say, hey, they hear better in their left ear. It's just helpful information. And what happens if you can't see and you gotta get to the bathroom? You might fall down. Yeah, these are things we gotta assess because we need to know the risks for our patients so that we can reduce those risks, right? We're gonna leave a night light on, or we're gonna make sure that they have their call light, or something to make sure, because they can't see, they can't hear real well. Chronic diseases like hypertension and diabetes will also affect your sight. Maybe they have cataracts or glaucoma. We can have some mechanical or chemical trauma that leads to sensory issues. Drug therapy like antihistamines and blood pressure drugs can cause vision changes. Also ototoxic, that's the ringing in the ears or some hearing loss, especially with diuretics like Lasix. If you push it too fast in the IV, or some people are just sensitive to it with higher doses. There are physiological consequences. There are changes to the body or to the patient that are a result of issues with sensory perception. Physical injury, that's the biggest one. Falls and other accidents. Inability to perform ADLs or ambulate independently. So like sometimes when people have their big toe, their hallux removed, amputated, learning to walk again is difficult because your balance is thrown off. You don't perceive the floor underneath you and the weight distribution. May not be able to solely rely on verbal communication, may not be able to use written communication if they can't see or hear. So that really changes how they interact with their world, and we need to make sure that we're making accommodations with them. Those are called interventions to try and keep them from harming themselves, and so that we're taking care of them. Sensory perception, we're going to ask about use of aids. Did they wear glasses? Did they get here without them and they really need them and they can't see you? Would you be a little scared? See? I would be. Hearing aids, don't lose them. If they've got them, get them a little denture box and label hearing aids on them or something so that they have a place to keep them and not on their tray where they get thrown away. Prevention, avoid risk factors. We're going to do screening for secondary prevention. Sometimes with like certain issues like glaucoma, we'll have eye drops or medications, hearing aids, and then just psychosocial support. Meaning people are there to help them get to the bathroom because they don't ambulate very well. That's an example of that. Sexuality, sometimes we're going to deal with folks who have different ideas about sexuality or their condition involves sexuality. Someone who has uterine cancer and then won't be able to have children, we have to take into special consideration about that. Some people who have erectile dysfunction. Sometimes there are issues with identification or they might be transgender. We just need to be very thoughtful and caring about that. Again, they can make whatever choice they want. It's not our place to judge. We're there to take care of them. But we do need to understand that sometimes when a condition affects their sexuality, it can make them depressed, right? If they've had surgery and they can no longer have sex, that could make them depressed. And it can cause poor self-image and self-concept. So, for instance, like folks who have a colostomy or are like heart surgery, is that what you're saying? A breast removal for like a mastectomy. Yes, all those things. There's more to the person than what's in the chart, right? more to the person than the paperwork you have to file. What we teach them helps someone manage better when they get home. So sometimes we have to address issues with sexual conduct and identity. Tissue integrity, intactness of the structure and function of the integument. So intact versus impaired. Is it closed skin? Is it open skin? Oh, you got a blister. It's impaired, right? Oh, you have an ulcer. It's impaired. Oh, you have a giant wound and I have to pack it with 6 feet of iodoform. Yes. Right? Oh, it's fun. It's a good time. Not for the patient. Really. So you can have partial thickness wounds that just go through the epidermis and dermis, so those aren't all the way down to the muscle, or full thickness where it does get down to the muscle and sometimes to the bone. Risk factors for issues with tissue integrity, say that 3 times fast. Issues with tissue integrity. Older age, again, we see this theme coming along, don't we? Older age, we don't perfuse as well. We're at bigger risk for clot. We have problems with our blood pressure. We have problems with our kidneys. Less tissue, less fat and muscle puts us at risk for skin breakdown. Sometimes, like my mama, she's got the thinnest skin on the planet. She can literally roll over in bed and have a skin tear. A skin tear is an impaired tissue integrity, right? Certain conditions make it worse. Malnutrition. My mom has moderate Alzheimer's, and she eats when they bring her food, so that's good. But before, she was malnourished, thought she had cancer because she lost 30 pounds. She'd forget to eat. She would tell me she would eat, but she would only eat if someone was there giving her food. And it didn't work if we just made meals and labeled them. We tried these things. She had to be with someone so that she knew she was supposed to be eating. Certain medical conditions, neurological disorders, diabetes mellitus, PPD, incontinence. We've talked about that a lot, how incontinence breaks down skin and can lead to infection. Pressure ulcers, we gotta be turning our patients in the hospital, especially when they're sick. Their skin is at risk for breakdown. If you don't turn them, they can literally have a pressure ulcer in your shift, depending on their condition. You know, if they're 25 and in great shape, and they can move around the bed themselves, awesome. If they are 65 and barely conscious, and their nutrition is low, and they're not getting any protein, and we haven't started TPN or tube feeds, we need to be extra cautious about, heel cups, Mepilex on the sacrum, making sure we're turning them and offloading them every 2 hours. And then we talked about cellulitis, that localized infection versus systemic infection, like sepsis or bacterial pain. Sometimes people with ulcers on the bottom, peri-area tissue damage, makes it harder for them to go to the bathroom, right? They're swelling, makes it harder for them to pee. Oh, or burns whenever they urinate or whenever they have a bowel movement. It just complicates things. It makes them uncomfortable. Make sure that you're doing a full skin assessment on your patient. People skip that. The other day I had 4th semesters and we were at CMH and we were doing an assessment, and the patient had come from a facility and he had a fentanyl patch on his back. Well, good thing we turned him over and looked at his bottom, right? Nobody knew he had a fentanyl patch on. So that's just one thing. But you can also find breakdown that needs to be treated or cleaned, or could be a source of infection. This is an example of a stage 2 partial thickness skin issue. Serum albumin and pre-albumin levels help us know more about tissue integrity. You're more at risk for skin breakdown if your albumin is low. And adding protein to your diet helps a little bit with that. They're connected. What? You made it through the big PowerPoint. Are you excited about that? Yeah? Okay, well, then let's jump into the next. Sherry next door is like, my goodness, this lady. All right, hold on. I got to share my screen somehow. Share. Share. Okay, we've already started talking about MedSurg stuff, and within that, we've mentioned that with age, sometimes we're at risk for more problems, right? Perfusion, skin breakdown, chronic diseases. Our organs don't work as efficiently as they once did, thinking about the kidneys. So now this chapter really builds on that information, because sometimes we have to take extra steps as nurses to protect our patients, to help our patients, to care for our patients. We've got to be able to identify what's unique or special about the older population. Aging population. You probably already know this, that our overall population is getting older, and that means a greater number of our patients will be elderly, and they have those specialized concerns we need to be familiar with. They typically have more risk factors for comorbidities and chronic illness, and they can also have a variety of social factors. You know, are you sending someone home that can't be safe at home? Do they, there's some complicated social issues, right? They don't want to leave their home, but they can't get to the bathroom, so they sit in their excrement all day. And now they have an ulcer on the bottom, and they've got a systemic blood infection. Okay, we got to talk about that. There's different options, right? Aging in place, independent living, assisted living, home health care, long-term care, cognitive and physical decline kind of can happen with aging as well. Concepts of elderly care all really relate around mobility. Remember, we said mobility is life. As we get towards the end of life, mobility tends to decline. Nutrition issues and cognition issues. And so those interrelated concepts are elimination, having problems, getting waste products out of our body, safety issues with sensory, and then slow healing and risk for infection with the tissue integrity. This is an important slide. Next door, this is an important slide. Next door, can you tell me which age group is the fastest growing? Old. And what, how old are old folks?
85 to 99.
85 to 99, that's right. That's our fastest growing elderly population. Wow. Wow. So we know that as we age, we have increased risks. How many risks, health risks, does this group have? 85 to 99. Wow, yeah. And then we got to start having conversations about quality of life, right? And comfort, and what the patient wants, right? Versus sometimes what the family wants. We'll talk about that in next week, I believe, but there's quite a bit to discuss ethically about, should we do every intervention always, or is there a time and place when if people don't want it, we focus on comfort instead, right? And again, that's their choice, but what if they're not able to make that choice because they don't have the cognitive ability? So we'll talk more about that next week too. It's a big discussion, hot topic. Old, fastest growing. Huh? Oh, honey, life doesn't get easier. So you get older. Have you ever heard somebody say, well, at least you have your health? Because when you hit 40 and you try to get out of bed, your back hurts because you slept more than 6 hours. I don't know how that happened, but it like snapped. Not everybody, probably not all chubby like me. But you know, you start noticing some changes with age. So some of those concerns are, hey, can they take care of their daily needs? A big issue with the elderly population is social decline. Whether they're at home, they can't get out very often, they don't see anybody, they can't go to church anymore, family doesn't visit, or they're in a nursing home and nobody comes to see them. COVID. So my mom was in assisted living over here at Butterfield, great place, because she wasn't safe to be on her own. She was not safe to have a stove. It wasn't safe to have her at our house. We tried that, but she would fall, hurt herself, leave the stove on. We can't be home 24 hours a day. We don't have enough money or insurance to cover 24-hour care, so, or family support to do that. So she has had an apartment at Butterfield. That's fantastic. And because we got her in before her Alzheimer's had become more progressed, She was able to establish routines. She could walk to the dining room. She had friends. They had little art group. You know, she did bingo. She really liked the bingo. That's a big deal, okay? She did stuff. That social interaction was great. I was there at least 3 times a week because I lived 5 miles away. My brother, the grandkids visited occasionally as life allowed, and we called her and talked to her. Then COVID happened, and we couldn't get to her. Couldn't see her. She was confused by the technology, and so those little FaceTime videos, she couldn't look at me. She didn't know what she was looking at. So we didn't see each other. She had hearing issues, and so she couldn't figure out how to turn her cell phone on. We experienced a decline because we didn't have that interaction. So that social activities are important, or you can have decline in your health. And that was true for my mom. She's now in long-term care, and I totally believe that it was because she had 9 months of no family, just on the phone. I got her a phone with a built-in amplifier where she could push the person's picture and call us. We did some changes. We tried to do more visits at the window, and then they wouldn't let us do the window anymore because people were opening the window. And then, you know, we tried to do all the things that we could, and it ended up where she was having falls. She wasn't eating because she would have to go to the dining room, and she wasn't feeling well, and she was depressed, and so she wasn't eating. And she had a fall, and we thought she broke her hip. She didn't, thank goodness. But then she wasn't able to like do her ADL, so she had to have some help going to the bathroom. So we moved her to long-term care where my niece, where her grandkids work, so she was able to see family there. She's been there since October, and that has helped her mood already. And like her weight stabilized, and you know, just having that interaction. So the point of that is social activities really do matter. And elderly people, their social activities go down if they're not careful. That's why senior centers are so important. They're not just something to do, it really affects their health to have those social activities. Nutrition and hydration, mobility, stress, loss, and coping. Their friends are dying, their family's dying. Now that's hard. And there's that emotional baggage that comes with all that loss, that grieving process. Accidents. Sometimes they shouldn't be driving. I have to take my mom's driver's license away. That went really well. It was after she wrecked her bed and split her radiator with my kid in the van going 50 miles an hour in the park. So impaired cognition can happen, substance use. Just because they're older doesn't mean they don't do drugs. Just because you magically get 50 doesn't mean that you're not doing drugs anymore. Right? Plus you got some access, right? Older people get more prescriptions for narcotics. Anyway, something to think about. And elder neglect and abuse, that's a big issue. Neglect and abuse can also be financial, right? Oh, grandma's staying with me because I get her check. But then I don't make sure she goes to her doctor's appointments. She hasn't moved. She's been sitting in her own urine. She's got skin breakdown, right? We're not actually taking care of her. Impaired nutrition and hydration is a big deal. Aging disrupts the storage, use, and absorption of nutrients. They can have diminished taste and smell. Tooth loss, we talked about those dentures, can all affect nutritional status. Less ability to taste sweet and salt leads to overuse, and their heart's already been used for 85 years, right? Gotta be a little use there, so it's a little stretched out, maybe. Cardiomyopathy. The more salt makes it harder on their blood pressure in their heart. Constipation. I don't know if you've taken care of very many old people, but sometimes they are absolutely focused on pooping every day. I've had a little old lady with a spoon from her lunch tray trying to dig stuff out. More than one, unfortunately. So the risk there is they can tear a hole, they can make an ulcer. Let's be careful with that. Right? So pain, anxiety, depression also with like social issues. They need to increase their fiber, their fluid, and their activity. It's kind of hard to do, right? They need to increase their fiber, fluid, and activity. There can be geriatric failure to thrive. That's when you see the folks that are really undernourished, and they can even have cognitive impairment from that. Impaired mobility, physical activity advantages. The reason we're pushing them to be active is decreased risk for falls. They'll have better balance, muscle tone, better sleep. You can find problems with sleep the older you get. Improve longevity and self-esteem, reduce risk for diabetes, mellitus, heart failure, and dementia. It's best to walk 30 minutes 3 to 5 times a week. Focus on functional. Focus on functional. You don't have to run a marathon. Just function. Stress loss and coping. There's speeds up the aging process. So we talked about people dying, loss of independence, going into Butterfield was really hard for my mom. Understanding, she was a nurse, she was an LPN at Northwood Hills in the 80s and 90s, and she's familiar with Alzheimer's, and to recognize the signs and symptoms for herself, it's devastating for her. She couldn't work the dementia unit. She just couldn't handle them, and now she was them. And she was aware enough that she knew it. And talk about anger and depression and anxiety, and she called them pity parties, and she would just sob because she'd be aware. And then as the dementia, as the Alzheimer's progressed, she would hyperfixate on things. And if that was what was in her mind that day, it might be a whole day of it. And so distracting, so important. You have to have people around you to distract them, right? So that long-term care facility is a wonderful asset. There are people there. And now she has a roommate, and that's good too because of nurse interaction. Relocation, we talked about that just now. Accidents in the elderly, that often brings them to the hospital. They had a fall, they broke a hip, they broke a leg, they broke their neck, right? We've got some sort of collar now they have to wear, or some sort of abdominal binder. They don't have any strength to put that on, right? Now they can't do their ADLs. We see all of these complicated factors. Falls are most common, and there's an increased risk for car accidents too. So fall prevention is huge. Most accidents occur at home. Most of them develop fallophobia, or fear of falling, because they want to stay at home and they know a fall can keep them out of their home. Got to assess for deficits and reduce risk. So a lot of what nurses do are fall interventions. Almost everybody in the hospital is a fall risk, but especially our elderly. Drug use and misuse. Talk a little bit about polymedicine and polypharmacy. As our body ages, we don't process out that medication very well. There's some criteria called Beer's criteria, and that is not a bar beer. That is a person who's created some criteria for certain types of medicine should be avoided in elderly because they don't handle it well. Their body doesn't break it down, doesn't excrete it, or it has too much risk with side effects for them. They should be having every 6 months a medication review. Let me tell you that gets thrown off, that gets missed and overlooked. You've got a patient that's confused, check their medicine list. Did something change? Did they take too much or too little? Right? If they're at home, did they double dose? That happens. They may not even realize it, right? You might have to have the family count the meds. Right? And family, we don't know sometimes. They don't want to tell us until something happens, and then we're forced to say, what caused this? How did we get here? Okay, she says she's doing great. She's great when I see her, but in the times I'm not there, she's obviously not. So checking for polypharmacy, looking at the Beer's criteria is important. Teaching folks how to track their medicine. A lot of people use pill boxes to help, and they can have it morning, noon, and night. For those folks who don't like pill bottles, they can put labels on their pill bottles, like yellow for morning and blue for night. Whatever, sometimes that'll help because some people are just dead set against having a pill box. Some moms are dead set against a Minute Maid, right? Then you got to get something with the root. You got to get something that helps them track their medication. Whenever we are medicating our patients, we want to monitor for side effects. They're more at risk for side effects, right? They don't process this medication well. They're more at risk for side effects. So we start low on the dosage and we go slow and we monitor closely. The reason that we do this is these age-related changes here. We have absorption issues. Sometimes there's less GI motility, less gastric blood flow. We've got more acid, likely got more GERD, right, once you hit 40. Distribution, body water, now albumin gets down, their cardiac output goes down, Their liver size and enzymes are messed up. The excretion, the kidneys don't work the way they used to. So that means they're not filtered. All this means there's not filtering out. It's staying in the body. That can cause changes in LOC, right, their level of consciousness. Medication assessment and health teaching. Common adverse medication effects for the elderly. Constipation, dehydration, weakness, anorexia. Not anorexia in the sense that I'm going to eat to be skinny, or not eat to be skinny, but I don't feel like eating. I'm not eating anymore. And we know nutrition is really important for healing and health, especially the protein. So we're going to assess medications every 6 months. We use the Beers criteria. Drugs that are at risk for increased complications are on page 61. We're going to collaborate with family, providers, pharmacists, and we're going to try to do once-a-day dosing. They're less likely to miss it if it's just once a day. If they have to take it every 4 hours, they're likely going to miss it. I'm going to miss it. Don't give me something every 4 hours. Give verbal and written information. Promote adherence. Check about if they have any supplements. Sometimes those supplements can interfere with absorption or can increase the effect of a medication, right? Encourage lifestyle changes. We're always going to push non-pharmacological interventions, things we can do without a prescription. Tell them not to share drugs. Impaired cognition is a problem. We're going to talk about the 3 Ds of aging: depression, dementia, and delirium. Veterans are especially susceptible to depression, PTSD, severe anxiety, substance abuse, and homelessness. Let me tell you that the biggest age group for suicide is elderly white males. My dad killed himself in November. He was a vet and had PTSD, thought he had that managed. I've been around him 40 years of my life. He had a safety plan. We took all of his guns. He'd hurt his neck, and he didn't want to be immobile, and he didn't want to wait for surgery. He wasn't convinced it would work. And so those mental health assessments are super important too, and sometimes they don't tell you. But sometimes they're more likely to tell the nurse than they will be to tell the family, right? So all of that assessment is important. Assessment, assessment, assessment. Depression is the most common mental health problem with the elderly. Just talked about, friends and family are dying. They're not in their homes anymore. They can't do things the way they used to do. How many of you like being independent? When I can't wipe my own bottom, I'm going to be depressed. I'm just saying, right? And it's not their fault. But man, the changes, that's a lot for the human mind and psyche to take in. We want to recognize that. We want to encourage them and uplift them and support them and educate them. So reminiscence and reflective therapies can be useful for older adults too. This is the depression scale for geriatric. And it really just identifies how many stressors are going on in their life that can cause them to be depressed. Dementia. So you don't have to have dementia just because you're old. But a lot of people do. It's a syndrome that involves slow, progressive cognitive decline that leads to chronic confusion. This is in blue. I imagine that's important, don't you? So dementia is a slow, progressive cognitive decline, right? Alzheimer's is the most common, and the second most common form of dementia is a multi-infarct dementia. So where you've had like a stroke. As a nurse, how would you describe dementia to the family or patient with a new diagnosis? Next door, what would you say?
Slow and progressive.
Slow progressive.
Slow and progressive. You might explain it in layman's terms like, hey, it starts out as forgetfulness, and then it gradually progresses to disorientation, right? First it starts out with, I can't remember a word, or I forget how to do things I used to know how to do. And then it gets to the point where we are disoriented. And remember, for nursing, assessing orientation is a big deal, right? Every shift, multiple times. It doesn't improve.
lot of Post-it notes.
A lot of Post-it notes, yep. We had a communication board for mom, so we kind of had like things for the day, and we had numbers that she needed. Pictures sometimes help. The important thing with dementia versus delirium is dementia doesn't improve, right? We can have some medications that can slow it down in some folks, but it doesn't make it better. Lots of times people come to the hospital, to the doctor, and we want, how do we fix this? There's not a fix for it. There's things we can do to help, but there's nothing that fixes it and makes it go away. We can slow the progression, but not stop it. 10 warning signs of dementia: memory loss, disorientation. My mom used to take Evan to school or pick Evan up from school when he was little, and the school was 3 miles from, so she was at Rose Parks at the time, and Evan was at the elementary school, 4 miles, not very far, and she got lost for an hour, and I had to come leave work to go get him because he's stuck in school. So that all of these pieces of the puzzle add up. One piece might not be a big deal, but all 10 pieces share a story. And all that comes out of the assessment. Delirium is different from dementia. Sometimes the signs and symptoms look alike, but knowing the differences help us distinguish between the two. Delirium is an acute state of confusion with a fluctuating onset, right? So it's a sudden onset. It's not something that starts slowly. It's something that wham, bam, thank you, ma'am, it's here. It's usually short term, and here's another key difference. It's reversible within 1 month or less. We treat what's causing the delirium. We can reverse it. Dementia, we can't reverse.
So is dementia second onset as well? Or can it be?
Dementia is slow and progressive.
Like, I know someone who was diagnosed with dementia, but it was like sudden onset. Like she got up in the middle of the night and wandered off like through the middle of town, and they found her. They diagnosed her with dementia, and from then on, she was put into a long-term care facility.
So she probably had signs and symptoms beforehand, and then she had some reason where she had a sudden decline. So that can be, it can be a stroke, because we talked about multi-infarct being the second most common type of dementia. And sometimes TIAs can have an effect, even though they're transient, they shouldn't leave long terms. It can be a trauma it can be an illness or a sickness, can cause a major issue. And with dementia, it sneaks up on you. All of a sudden, it's a problem because we didn't see all the little pieces. Mom thought that someone broke into her trailer in the middle of the country in Humansville and stole her red ring. Not her TV, not her cash in the chicken pot, not anything else, that one red ring. And she was convinced, right? Mom thought she'd be in the century. Nope. Start with dementia. And then when I took her to the doctor, when the doctor assesses for dementia, it's a rule-out diagnosis. And they have to be a baseline. You shouldn't get a dementia diagnosis in the hospital because they're not a baseline, right? That's part of, are we seeing delirium, are we seeing dementia? And so they'll do a CAT scan to see of the brain, the head, to see if there's any changes that might cause issues. They're going to check electrolytes. They're going to check anything that's going to change the LOC. And if all that's normal, and we've got the signs of symptoms, and we see memory impairment, then they get a diagnosis. It's harder to diagnose, and because of that, it takes lots of steps. There can be many causative factors on page 63 in your textbook. Some of them including, this is for delirium, drug therapy, fluid and electrolyte imbalances, infections, pooping too much or not pooping enough, surgery, metabolic problems, nutritional deficiencies, and hypoxemia, not getting enough oxygen. Screening for delirium, we can use that confusion assessment method, the CAM. If I can finish this up in the next 5 minutes, we're going to do that. Yes, Londa. I can't hear you, I'm old.
Can you have dementia and delirium?
Yes? Oh, and be young. You can have both at the same time. You can have delirium and be young. And I suppose if you had the multi-infarct dementia, you could be young. You don't have to be old to have a stroke, unfortunately. Good question. Typically, yes, but there could be situations where This chart just shows us delirium versus dementia versus depression. The big is that delirium is a sudden onset. Dementia is insidious, meaning months to years. It's that slow progression. Delirium can come and go. Dementia is progressive. It just keeps getting worse. And depression can be chronic. And especially social activity and limited social interaction has an effect on depression in the elderly. Substance abuse, we kind of talked about this already. 4.3 million people have substance abuse that are over 50. 1 out of every 8 Americans who seeks out treatment for substance abuse is over 50 years of age. We do the CAGE assessment to assess for alcoholism. This just has a little bit of information that substance use can lead to diabetes, hypertension, heart disease, isolation from others. We've already talked about how important social support is, depression, and a delirium whenever they get really sick. This is the CAGE test. It has 4 questions. Have you ever tried to cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt bad or guilty about your drinking? Have you ever had to have a drink in the morning, an eye-opener to start the day? Those are signs of a problem, not just social drinking.
Love your drinking. I feel attacked.
Okay. Neglect and abuse is a big issue. Physical, use of physical force, bodily injury, it can be financial, it can be emotional. Don't humiliate the elderly. Don't make them feel bad if they've had an incontinence episode. Right? Like, my heart just hurts. Carefully assess, as a nurse, you are a mandatory reporter. Bruises in clusters or irregular patterns are in. You have to be careful because sometimes they're old and they're prone to falls, right? Burns to the buttocks, soles, or feet, cigarette burns. Unusual hair loss, multiple injuries, especially fractures in various states. Healing, sleep, nutrition, incontinence. Sometimes insomnia is a big issue for elderly people, and that can change your cognition, right? Confusion and falls. Avoid multiple drugs. So that polypharmacy, that Beers criteria is important. Reorient. That's one of the things you can do as a nurse. Reorient your patient a lot. Provide comfort and promote sleep. Make sure you're doing a fall risk assessment. Watch for a recent fall history because they're more at risk for falling with you. Toileting falls are common. Use a nightlight. There's a best practice chart on page 67 for assessing risk factors for many falls. This is an example of a Morse fall risk assessment and the fall score. We use this at Cox. It's one of the different assessment tools that you can use to evaluate whether they're high risk, moderate risk, or low risk. Restraints, sometimes we have to use them in the elderly to keep them safe. There are special considerations for restraints. It takes away their human right to choose. So we use them very limited. It has to be that they're harming others or harming themselves and that no other intervention is going to keep them from doing that. We use the least restrictive device first. We check the patient every 30 to 60 minutes, and your protocol might be different. When we have restraints for violent behavior, it's every 15 minutes at Cox. For nonviolent behavior, it's hourly. You can release restraint every 2 hours. Your order is for a 4-hour period. So you have to continually get, that's for violent restraint. You have to continually get your orders updated. Sometimes there's a chemical restraint where we might use some Haldol or some sort of medication for sedation. Sometimes you'll have sitters. Start with the least invasive, right?
Instead of release the restraints every 2 hours.
Only if appropriate. So like if there's still, you know, I had a patient who thought dogs were burning in the corner. And she was in hell. And she was gonna get out of there, right? And there's no reorienting her, right? And we already tried to sit her, and she'd already hit people. It's hard for me to see them restrained. Sometimes, like when people are intubated, they'll put restraints on their hands so they don't pull that out. That's for safety. That's a reasonable reason, right? They're gonna do more harm to themselves. by being unrestrained than being restrained. Skin breakdown, this is a lot of what we've already talked about. I thought this chart did a good job when you're showing where common pressure sores develop. When you're doing your skin assessment on your patient, these are the places to look. Right? Their heels, their folds, shoulders, back of their head, their elbow. Clean skin, moisture barriers, good idea for prevention. Transition management and care coordination, that's where we try to help coordinate resources outside of the hospital or the facility where we're working. Okay, we talked a little bit about dementia. We talked a little bit about orientation and consent. When we give blood, what do we have to have from the patient? Consent, right? And in order to give consent, the patient has to be alert and oriented. And who does the assessment? The nurse. That means that you are helping decide if that patient can make decisions for him or herself. If you suspect that they can't, they can do different, like they can do a psych eval, they can do a neuropsych eval, they might have to file for guardianship, but you are the one that says, yes, when they sign this piece of paper, they were alert and oriented and able to make their own decisions. So I'm going to give you a scenario that might be a little bit tricky, and we're going to talk it through, okay? Dementia is a progressive disease that starts with forgetfulness and moves into disorientation. So you can be at different paths on that spectrum, right? You can be at the beginning where you're just forgetful, or you can be towards the end where you don't know who you are. Once a patient has a dementia diagnosis, can they still make their own choices about care? Yeah, depends on your assessment, right? So yes, as long as they are alert and oriented, they can make their own choices for care. You assess whether the patient appears competent, understands the procedure, and is alert and oriented. Just because they have a dementia diagnosis, it doesn't mean they cannot sign consent. They don't automatically defer to their next of kin or their DPOA. If they can make that decision, they're the ones responsible for it. Even if the DPOA wants something different done, if they have appropriate cognition, it's their choice. It's their body. Yes?
Well, you said that it's a safe progression, so I don't know if it's a question, but if they go from one day to one day and they're able to sign consent the next day, they're just not going to pay them and they can go back again the next day.
So the question was, can that change from one day to the next? And the answer is absolutely. It's a constant assessment. Not so much with dementia fluctuating in that way, but delirium can. And when you have dementia and you go to the hospital, that change alone can throw you into hospital delirium. So that's a good question. So you can assess them and get consent for blood administration and they'll be alert and oriented, but the next day they won't be with it and you'll have to call and get consent from someone else. The next of kin, the DPOA. A disoriented patient cannot sign consent. Next of kin or durable power of attorney must be contacted. So the difference is the assessment that you do that determines orientation. Does that make sense? It's not the fact that they have dementia. They could have it or not have it. What makes the difference is, are they oriented?
You have to do orientation times 3 or times 4 if they know who they are, where they are, but they don't know who they is.
So you might do some further assessment because sometimes days linger together and you would just probe a little farther. Some other questions that I ask are like, who's Mickey Mouse's girlfriend? And what are you here for? Tell me why you're here. You know, so you can discern, you can assess if they're oriented. Does that make sense? If they think it's 1979, but if they're like, oh yeah, it's October and it's November 1st.
So you can continue to ask questions and eventually determine that they're coherent.
Yes, then they can have consent. But it's your assessment on the line. Good questions, good questions. Okay, that's it for this slide. I know we only have 10 minutes. And I have a case study. Do you feel like powering through? I see no's. I see no's. I'm going to pull it up and just go over it a little bit together. The case study applies the information that we had talked about here with our lecture. While I'm getting that ready, I want to talk a little bit about clinicals. We have our first week of clinicals next week. I'm going to come into Mrs. Mock's class, and we're going to go over some details about clinical. I had a lot of information in this class, so there wasn't really time for it. She graciously offered for me to come in and talk to you about it. That way we can talk about expectations and how things will work, you know, just so you have an idea about it. Does that make sense? Might help a little bit with anxiety too. Did you get that next door, guys, that we're going to talk about clinicals in Mrs. Mock's class?
Yes, we did.
Okay, good. So this is a case study. And you may have done case studies before, have you? Okay. So it involves sort of like SOAP note information. It involves like assessments and gives you details. This is from a case study from MedSurg. And it is talking about Emily Jones. The following case study illustrates principles of evidence-based care of an older adult experiencing blank. By the time we're done with this case study, you'll be able to fill it in. You'll be able to know. I'm just going to talk through it for a few minutes. I know it's almost time to go. I won't keep you late. I want you to connect the dots from the information we took from the textbook and see it in a scenario with a patient. When you go to clinics, when you go to clinicals, you're looking to see these signs and symptoms in your patients, right? You're looking to be able to identify or to use the information you learned in class as you see it in person. And that's that bridge from going from textbook to practice, right? That bridge to practice. And we'll start that process with clinicals. Case studies also help with that. Miss Emily Jones is an 89-year-old woman. Which category is she in if she's 89? Old. She's the biggest population of elderly, right? And she's admitted to the hospital with pneumonia. She probably has something else, right? Or we wouldn't do this case study. So a little bit of background about Mrs. Jones. She lives alone. She requires some assistance with her daily living. She gets Meals on Wheels. She has a home health aide 3 days a week. And she has a daughter who comes by and assists her on weekends and visits a couple times through the week, whenever the home health aide does it. Mrs. Jones' daughter is with her at the hospital. You as the nurse know that it's wonderful to help her there, to help get some more information, right? To paint a more detailed picture. Assessment on admission says that her vital signs, she has a temperature of 102. What could that indicate? Infection. I've already told us she has pneumonia, so that makes sense. Her pulse is 70 beats per minute and regular. Is that within normal limits? Yes. So by knowing our normal limits, we can tell, okay, her heart rate's appropriate. Her respirations are 24 beats a minute, breaths a minute, and shallow. That's consistent with pneumonia, right? It's a little fast, and it's shallow. We got some fluid in the base of the lungs. So we're breathing faster and more shallow. Our blood pressure is 140 over 68. Our lung sounds coarse, diffuse wheezing throughout the lung fields. So we've got some inflammation in there. And we've got a productive cough with thick yellow sputum. What does that thick yellow sputum come from and indicate to us? Speak loud. From the lungs. Infection in the lungs, that yellow and that thickness, and that's all consistent with pneumonia. Good. Our oxygen saturation is 90% on room air. Our skin sugar is poor, which might be a sign of what? Oh, I love you. Yes, good job next door. Vowel sounds are hyperactive, and she's had a lot of loose stools, right? So those vowel sounds are hyperactive because she's had diarrhea. And it's pushing through all of that. So we know she's at risk for an acid-base imbalance, right? Yes. She has pain when she breathes in or upon inspiration. That's common with pneumonia. and she has no hearing loss, but she wears glasses. What common factors are present that contribute to delirium based on her assessment? You can find this information on page 3.
I guess dehydration.
Fluid and electrolyte imbalance. What's that caused from? Yeah, and if we looked at her meds, which we hadn't yet, she had a diuretic. That fever can make you dehydrated too. Good. Infections can cause risk for delirium. So how did we know that she had an infection? What were her signs and symptoms? Yeah. Yep. Increased respiratory rate, and her oxygen was 90%. She's at risk for hypoxemia, right? She's at 90% sitting up in bed talking, but does it drop when she coughs, moves, or sleeps? Right? And then she has pain. Pain can cause delirium as well. And she's in the hospital and not her home. Those are all factors that can contribute to the onset of delirium. So we would know as a nurse that she's at risk for that, and we're going to watch for it. Miss Jones has a past medical history of congestive heart failure and hypertension. Her usual medications for her heart failure include digoxin, DIG at 0.250 every day, hydrochlorothiazide, a diuretic, at 25 milligrams per day, and potassium every day. Before admission, her family nurse practitioner had also given her an antibiotic. Are there any of her home medications that are concerning to you?
Yes.
So we have that. So I hear diuretic can cause dehydration. Good. Anything else? Is there anything on the beers list from your textbook, from your chapter? Yeah, the DIG. The dose is especially high. It's recommended not to exceed half that amount because of the increased potential for harm and her age. But you're right also about the hydrochlorothiazide. Mrs. Jones exhibits difficulty maintaining attention with disorganized thinking and she's hyper alert. The patient attempts multiple times to climb out of bed and repeatedly states, I gotta go home to my cat. The patient is restless and has increased motor activity, so her legs are moving nonstop. The nurse asks the daughter to describe her usual cognitive state. Why is this important? Baseline. Is this something new or is this something chronic? If it's new, we're more concerned about it. If it's new, it's more likely to be delirium. The daughter says no. The mother's clear as a bell, and she's always coherent, and she's usually a calm person. This odd behavior started suddenly and got worse when she got a fever. Let's do a CAM assessment, which is our confusion assessment, right? Helps us determine if we have delirium on the information that's been provided. Let's look at number 1. So in order to have delirium, she has to be positive for number 1 and 2, plus either 3 or 4. Okay? Let's look at number 1. So a positive CAM assessment would have an acute onset and fluctuating course. So did this start suddenly? Yeah. And so we know that she wasn't confused and now she is, so that's that fluctuating, right? And it might get worse with her fever. So when her fever is controlled, maybe we would see a change in it. That's part of anticipating that fluctuation. So she's positive for feature number 1. Feature number 2, did the patient have difficulty focusing attention? Yeah, how did we know that? She's like, I don't care about this pneumonia and I can't breathe, but my cat, I do care about. Okay, so she's positive for number 1 and number 2. To have positive features of delirium, she also has to be positive for either number 3 or number 4. Number 3, was the patient's thinking disorganized or incoherent, such as rambling, unclear, or unpredictable, switching from subject to subject? Yeah, that cat thing, perhaps. I could see that. And number 4, do you feel like she's alert or lethargic, hyper alert, difficult to arouse, or in a coma? Yeah, she's trying, hyper alert means she's trying to get out of that room. She's trying to elope. She's gonna go back to that cat, right? So is she positive? Yes. Yeah, I think so too. And those are the reasons why we just discussed them. So from this information, we can tell that she has delirium. We use that assessment. So in particular, she's experiencing hyperactive delirium. What we need to recognize as the nurse that the following factors have probably contributed to it. We've already talked about this: elevated temperature, dehydration, diminished oxygenation, and ineffective airway clearance from the pneumonia, the fluid in the bases of the lungs, unrelieved pain, right? So the hospital gave her 2 liters of oxygen for comfort and gave her some fluids for rehydration, Tylenol for the fever, antibiotics for the infection, and an opioid pain medication for the pain as needed. Right? And that's supposed to help her infection, her hydration, some of the same issues that are causing her delirium. So for us, well, how are we going to manage the delirium? What are interventions that we're going to do as the nurse to manage delirium while the patient has it? Oh, I hear next door too. Reorient the patient over and over and over. We're going to enlist the help of the daughter, right? If she can stay there, that's all right. Based on our policies right now, visitation's hard, but she probably helps calm her mother down. If they have a toxic relationship, get her out of there. But if she's helpful, it's good to have her there. It would be therapeutic. Use the dry erase board for communications. Make sure people's names are written down so she knows who she's working with. Make sure your badge is clear. Communicate with staff about the fact that she has delirium and tell them they need to introduce themselves too, right? They need to be reorienting. Enlist the help of those that work with her. The nurse, I got that all wonky. The nurse needs to assure Mrs. Jones, ensures that she's wearing her glasses. If she's not wearing her glasses, she's at risk for what? A fall. You do not need your patient to harm themselves, and you do not need the paperwork of a fall. Recognize that safety is a priority for the patient experiencing delirium. They're impulsive, right? If they're impulsive, they're at risk for a fall. They might not watch what they're doing, and they might fall down, hurt themselves. You can only have 2 side rails up, right? You can technically have 3, but you can't have all 4, and you can't have them pushed against the wall, or that is a restraint. You don't have an order for a restraint. And we want the daughter to tell us when she's leaving. Why? Yeah, we're going to have to watch her a little closer. We need to do bladder training or toilet training. Why? Check, check. So I heard, so she doesn't fall, so someone's with her and we can keep her from eloping. And also, in case she has any incontinence, we're reducing risk for skin breakdown. Get rid of clutter, reduce stimulation. When Mrs. Jones' temperature and pain decrease, the nurse notes that her mental status improves. So she reperforms, or he reperforms the CAM test, and it's much improved. And they continue all of their interventions throughout her hospitalization because delirium can come and go. Does that make sense? Awesome job. I know we just walked through it. I was going to have you have a paper and fill things out, but I wanted you to see that process. What's going on with the patient? How did all the stuff we just talked about work with the patient scenario, right? What is the assessment data that we see? What kind of example would we actually see on the floor of the unit at the hospital? You guys have been fantastic. I will get your stuff graded and posted today before I leave. I will see you again at farm class, and we will talk a little bit about criticals and what to expect. Thank you, guys.